Hi guys, good evening. Hope all of you are doing good. Now, me myself, Dr. Kunal, I welcome you on behalf of Miss Team for this recall session of 4th June 2022 FMGE exam for the subject of pathology. Now, we hope that your exam went good. We hope that you are feeling confident, and we would request you to take a break now and unwind yourself, relax a bit, and do not think about what has happened yesterday. Let the result speak for itself. This is purely and purely a recall based question. And, first of all, I would like to, give a thanks to all the students who have tried their level best to give me the questions for the subject of pathology. I would also be requesting you that please, if you find any question which is not exactly with the options which were given here, or the framing of the question is different, we would sincerely request all of you who are watching this video that if you have any other thoughts about it, please mention it in the comment box. It would be very beneficial for us. Now, as far as the exam for the subject of pathology goes, the pathology is divided into three parts. That's general pathology, hematology, and systemic pathology. The questions which we have got more or less from these particular topics. General pathology had 9 questions. Hematology, again, we had 9 questions from it. And from systemic pathology, we have 6 questions from the part which we have studied together in MIST. Now, I'll start with the recall. The first question it was something regarding the dystrophic calcification, and it is dystrophic calcification is seen with. Now, the options which I have got, they were hyperparathyroidism, atherosclerosis, vitamin D disorder, or hypercalcemia. Now, we do understand that, when we studied about the dystrophic calcification, or rather the calcification in the classes, pathological calcification, there are 2 types, dystrophic and metastatic. And we have done this very clearly in our classes that the dystrophic calcification would be seen in dead and dying tissues, and the serum calcium levels in these patients are generally normal. Whereas with the metastatic calcifications, they are seen with normal cells, and the serum calcium levels will always be rise in metastatic calcifications. And I've given you the mnemonic for the dystrophic calcification, which was this ART, and atherosclerosis being one of the options. And this exactly you got in your examination question as an option. So dystrophic calcification, obviously hyperparathyroidism would be giving you the metastatic calcification. Hypercalcemia again is a feature of metastatic calcification because the serum calcium levels would be high over there. And vitamin D related disorders will also be giving you metastatic calcification, not the dystrophic calcification. So the correct answer for this question would be B, atherosclerosis. Moving ahead to the second question, a female went for camping with her friends. She had a bee sting which resulted in edema, redness on face, and difficulty in breathing. There were some students who were telling me that there was a history given that the doctors tried to resuscitate her because she was having too much difficulty in breathing. But what exactly they had asked in this question, that what is the type of mechanism responsible with this kind of reaction? Now we have by seeing the options, we could understand that they are talking about hypersensitivity at this time, and suddenly a bee sting happened. This is a repeat question actually. Last time in June exam, again they asked the same question, and but in a different language, but the same question. And we do understand that this is type 1 hypersensitivity reaction, which is called as anaphylactic or allergic hypersensitivity reaction. And the antibody which is responsible is IgE. The mediator which is responsible is histamine, and the cells which are responsible, they are your mast cells. And we have done this very carefully and clearly in our classes. These are all your missed classes notes where we have written this. So types of hypersensitivity we have seen, type 1, where we have specifically mentioned that IgE is the antibody responsible for that. We have already mentioned that the mast cells are there which contains the histamine, and histamine is the reason why we are seeing the important functions like the vasodilation, the increased vascular permeability, or the contraction of smooth muscles. So because of this vasodilation and increased vascular permeability leads to swelling, vasodilation would lead to erythema, contraction of smooth muscles led to the difficulty in breathing of this patient. So the correct answer for this question, because this question is from type 1 hypersensitivity reaction, the correct answer would be IgE mediated hypersensitivity. Moving on to the third question, myasthenia gravis is which type of hypersensitivity reaction? Very basic question, very simple question. These kind of questions have come after a year because the last time they asked such a direct question from pathology, from hypersensitivity, was in December 2020. Now, last whole year they didn't ask, but we have done this very carefully in the classes again, and the mnemonic which you all must be knowing for type 2 hypersensitivity reaction, that is your my blood group is Rh positive, which is a very popular mnemonic, and M stands for myasthenia gravis. This is a mnemonic for type 2 hypersensitivity which we have done, and this is what they have asked in the exam. Now, moving on to the fourth question, cells responsible for graft rejection. Now, graft rejection, again, something which has been taught very well in the classes, all the types of graft rejection, and we have discussed that for a graft rejection, there are T cells which are basically responsible and the antibodies. So the cells they are asking, so obviously the correct answer for this would be T cell. The other options were NK cells, B cells and plasma cells, but then the major cell responsible for graft rejection was T cells. Now, somebody told me that, there were time mentioned in this. If there is some extra information mentioned or the question for framing is different, please do your, write your views in the comment section so that it can help us and your future aspirants. Moving on to the fifth question, pattern of inheritance seen with the disease inherited from grandmother to father and then father to his son. So basically a family tree was given, and in that pedigree they were telling that the grandmother had the disease, then the grandmother passed the disease to her son, and then that son of hers, he passed the disease to his son. So basically generation gap is not there. They asked the pattern of inheritance. The options were autosomal dominant recessive, X-linked recessive and X-linked dominant. Now, if you can recall from the classes, this is an autosomal dominant pattern. Why it's an autosomal dominant pattern? See, there is no generation skipping which is there. So, in the autosomal dominant pattern, we are not seeing skipping of generation, which we have, written very carefully that every generation would be involved in a dominant pattern. So, you can get confused between two options here. But see, it can't be recessive because the generation skipping is not there. So, you could be confused between autosomal dominant and X-linked dominant. Now, when we are talking about a X-linked dominant, you must be remembering one more phenomenon, that is your crisscross inheritance. So, father never transmit the disease to his son if it's an X-linked disease, because father transmit his X chromosome to the daughter, not the son. So because the father has transmitted the disease to son and there is no skipping of generation, the answer becomes autosomal dominant. Then neural tube defects shows which pattern of inheritance? Now, neural tube defect very commonly, cleft lip, cleft palate. So when we were talking about the genetic mutations and the pattern of inheritance in genetic mutations, we discussed properly that any kind of genetic disorders, they would be the inheritance pattern could be a single gene defect or a multi-gene genetic defect. Now, single genetic defect could be Mendelian and non-Mendelian, and these were the examples we studied with that very thoroughly we have studied that. And then there was some multifactorial multi-genetic disorders in which the first thing was cleft lip and cleft palate, and this is one of the neural tube defects which we see. So again, the options given were autosomal dominant, autosomal recessive, X-linked dominant and multifactorial. So multifactorial being the right answer in this question, because it involves many genetic mutations to lead to these neural tube defects. Then seventh, a couple is trying to have a child for past 2 years. After unsuccessful trials, they went for respective examinations. The investigation for female came out to be absolutely normal, but the male shows presence of gynecomastia, scanty pubic hairs, atrophied testes. Comment on the diagnosis. Now, students have specifically mentioned that they have given the features of Klinefelter syndrome in a manner of A, B, C like that. So I have tried to make the same thing, and obviously you can understand a male having gynecomastia, a male having very scanty pubic hairs, and a male having a very important thing, atrophy testes. Phenotypically a normal male, but then genotypically will be having a problem. Klinefelter syndrome, 47XXY, the most common cause of secondary male hypogonadism. The correct answer for this question is Klinefelter's. Now, it can't be Turner's because Turner's is the most common, cause for secondary. The secondary sexual characters are absent in Turner's for a female. So it's Turner syndrome is the most common genetic cause for a female hypogonadism. So it's here the male is having atrophied testes. So it can't be Turner's. Now, Down's, it's trisomy 21. Nothing to do with the atrophied testes or gynecomastia, nothing to do with that. And likewise, Edwards syndrome is trisomy 18. So again, no relation with the sexual chromosome here. So it is Klinefelter syndrome 47XXY. Now this again, we have done, in our classes. Now you can see the most common genotype is this, most common cause of male hypogonadism. And we have written already that, in this image you can see that there could be minor breast development. You can see that the pubic hairs are less, or it is a female pattern pubic hairs, and testicular atrophy. So these are the exact words they have used in the exam, and I hope you people were able to solve the questions. Now then this question, students were not able to give me the proper, the scenario which they have mentioned in the exam. But what they have mentioned is that they could tell that it's a case of neurofibromatosis, because this was the word that was mentioned. So café-au-lait spots, and we all know they are seen with neurofibromatosis, and we know that neurofibromatosis, they are the pattern of inheritance again. So you can see how many questions from genetics have come this time. So pattern of inheritance they have asked, and again neurofibromatosis, I hope you people have learned this mnemonic for autosomal dominant, that autosomal dominant people, they don't have AIM, and in the end of this don't have AIM, there is neurofibromatosis. So it's an autosomal dominant disease, the pattern is autosomal dominant. And I hope that you people remember that I have told you multiple times that it's very important to know the examples of these diseases, these mnemonics, because they are very, very, very important. Then this question, I have taken this question because, people have told me that there were definitely a question on cell cycle, but they were not able to tell me exactly what they have asked. So it's a humble request from my side that please, if you recall, anybody, whoever is seeing this video, if you recall the question, please put in the comment section, so that, as I said, it might help your juniors. Now, the 10th question, macrocytic anemia will be seen in. Now, very simple mnemonic for the options which they have given. You have to rule out the options. Sideroblastic anemia gives you microcytic anemias. Then anemia of chronic disease again can give you microcytic and normocytic, but microcytic anemia has no macrocytic anemia and anemia of chronic disease. Then your thalassemia again. It's microcytic anemia which you see in thalassemia. And in the liver diseases, yeah, you can have macrocytic anemia. And when we are doing the classification for anemia, I told you that, when we are talking about a microcytic anemia, the mnemonic is SITA, very popular mnemonic. I'm studying it from, my college days. And macrocytic anemia, the mnemonic which I gave you was MDH. And here I have mentioned that you can see that in liver diseases. And that is what students have told me that they had mentioned. So again, the answer for this question would be liver diseases. 11th question, a patient is suffering from iron deficiency anemia. What is the stain used to confirm the iron stores depletion? So they've already mentioned that, iron deficiency anemia is happening. They're asking about the stain for iron. And we have discussed this in the classes again. The correct answer is Persian blue. Azarin red can't be. Methylene blue again for reticulocytes. Persian blue is for iron, and Voncosa is for calcium. So Persian blue is the stain. And again, from the notes you can see that we were talking about the hemosiderin pigment. I told you it's a hemoglobin derived pigment, and the stain which we are going to use for this is Prussian blue or pearl stain. So that's the correct answer for this question. Then again, a 12-year-old male presents with splenomegaly, and the following CBC findings are as follows. TLC was high. What students have told me, there is somebody is saying, sir, the blast percentage was not given. Somebody was saying that blast percentage was given. My take on this is that if the blast percentage happened to be 45% blasts, and they are asking which kind of leukemia is going to be, and they have given you the options of lymphocytic and myelocytic leukemia, both them, lymphoblastic and myeloblastic leukemia. So first thing is, because they have mentioned the myeloblasts here, so obviously this is going to be a myeloid leukemia, number one. Now you can rule out that it can't be lymphocytic leukemia basically. So because it's a myelocytic leukemia we are talking about, so now we are confused about AML and CML. So when we are differentiating AML and CML, do not go with the age or anything here. Do not get confused about all that. The only thing is, what is the first criteria on which we are discussing what is an acute and what is a chronic? It is the number of blasts we are seeing in the blood or the bone marrow. So if it is more than 20 or equal to 20% blasts in the blood or the bone marrow, you call it as acute leukemia. And if it is less than 20%, 10 to 19% blast in bone marrow or the blood, then you call it as chronic leukemia. So you are getting myeloblasts which are 45% in number. So obviously it is more than 20%. So the correct answer for this question would be acute myeloid leukemia. And we have already in the acute myeloid leukemia, we have discussed this, that you will have more than equal to 20% blast in the blood or the bone marrow. Again, moving to the next question, 13th number. In middle-aged men, on urine examination shows Benzzone's proteinuria. On X-ray, multiple lytic lesions are seen. Protein found high in this condition. Now, if there is any other history which you remember from this particular question, please let me know. But then this question seems to be a question which is, moving towards multiple myeloma. And in the multiple myeloma, we have discussed that, there is Benzzone's proteins in the urine. You will see there would be multiple lytic lesions on X-ray. We have it, osteolytic lesions in multiple myeloma, and we have M spike over there. So, and that M spike, we have discussed this, this M spike happens in which zone? The M spike, you can see from this, the M spike in multiple myeloma would be happening at the gamma region, because the antibody which you are seeing with multiple myeloma is going to be IgG, and IgG antibody settles on the gamma region. So, obviously the correct answer for this question would be gamma globulin. So they have given you, alpha globulin, beta 1 and beta 2. So gamma globulin will be more here in this question, as discussed in the classes as well. 14th number, a middle-aged man presented with hypercalcemia, features consistent with renal insufficiency. On CBC, RBC count was seriously decreased. On X-rays, again multiple lytic lesions are seen. Comment on the diagnosis. So it was a straightforward question which come from multiple myeloma. You are seeing the features of CRAB. You are seeing, this hypercalcemia, then, the renal failure, then you are having the anemias. So, and, bony lytic lesions are also there. So, CRAB is present. Was there anything else in the history of this patient? Had they mentioned something else? Please let me know in the comment section. But whatever students have told me on a recall basis, this and on the basis of what other, options we have, the correct option for this question would be B, multiple myeloma. Again, we have discussed this very well in the class regarding the multiple myeloma. Then 15 number question, a child visited the hospital with a mother with complaints of severe fatigue, lethargy, pallor and irritation. He was a known case of iron deficiency anemia. He is on oral iron supplementations. After reviewing the child, doctors are planning to start with intravenous iron supplementation. So now you are giving intravenous iron. What next test should be done? Now, when we were discussing iron deficiency anemia in the classes, I told you that, for the best thing about finding out the iron deficiency anemia, doing the iron profile, and the best test I told you about, finding out that whether really the iron stores are depleted. You need to find out the iron stores, and if you really need to find out the iron stores, what you can check in the blood of the patient, you can go with serum ferritin, because serum ferritin is a reflective value of what ferritin molecules are stored in your body. So more are the ferritin molecules stored inside your body, more will be, reflected in the patient's blood. So if you're getting less serum ferritin, that means probably the patient is having iron deficiency anemia, and they have already mentioned in the question that it's a known case of iron deficiency anemia. They're asking what test should be done, and we have specifically, read this, that the most sensitive and most specific test for iron deficiency anemia happens to be your ferritin, ferritin, you will try to count the ferritin, and if you are quantifying the ferritin, you understand that how much you have to give, what is the scenario inside. Other things like TIBC, hemoglobin value or hematocrit, I mean, they are not as informative as the ferritin. So quantification of ferritin will be a better option here. If there were any other options, again there was a confusion in the options here, so please let me know if you have any other views about it. Please let me know in the comment sections. The most abundant plasma protein in the body, it was a very straight question, it's albumin. I hope everyone has done this question right. Albumin is the most abundant plasma protein inside our body. Test not done during blood transfusion. So if you are transfusing the blood, we have discussed it multiple times in the classes, if you are transfusing the blood, so blood transfusion, obviously HIV markers you definitely are going to do. When we're talking about hepatitis, hepatitis B and C, because they have given, yes, definitely we have to do, because hepatitis B and C, they can transmit by sexual route, so, and by the blood route as well, the horizontal route. So you definitely have to check for hepatitis B and C as well. But the hepatitis which is not related to any blood transfusion thing, or which can't be transmitted by blood, that is hepatitis A, because it's fecal-oral. So the best option, the best answer for this question is going to be your hepatitis A. 10-year-old child come to the clinic. Her mother gave the history of repeated blood transfusions over the past. She is presently worried about her son as earlier he was maintaining good grades in the classes, but now from past few months his grades are deteriorating and he remains lethargic. His blood investigation shows crescent-shaped RBCs. What should be the next step in management of this patient? Now, by the look of this question looks like a question of sickle cell anemia. Now, in the page, is there anything they have mentioned here? I don't know. But if they are saying what should be the next step, you are seeing the crescent-shaped RBCs directly on the blood smear. That means it's a serious case of sickle cell anemia. Now, if it's a serious case of sickle cell anemia, the best treatment which you can give, because it's a child. So, see, the ideal treatment would be, getting into an invasive treatment and giving and treating the patient. But then here, by the options which are given, the best thing is that because there might be, the child is becoming lethargic, the child is not keeping up the pace with the other students of the class, maybe the hemoglobin values are going down. So in the management, obviously you will transfuse the blood because the RBCs are being lysed by the spleen. So you need to transfuse the blood as a next step of management in these patients. IV antibiotics, yes, you can give in the patients of sickle cell anemia because of so much of injury and the the infections these patients have. But then it would not be the next step. There is no history of that here. Normal saline will not help, and you cannot leave this patient for observation because already directly you are seeing crescent-shaped RBCs in the blood smear. So it's a serious case. So you need to transfuse the blood. Out of the given options, I think this would be the best option available. A known case of diabetic patient came to the hospital with pigmentation of skin over the arms. He also found out to be suffering from micronodular cirrhosis. On biopsy, iron deposits are seen. Comment on the diagnosis. So, by the clinical history what they have given, it is clearly a case of hemochromatosis. So they are talking about hemochromatosis. See, alpha-1 antitrypsin deficiency will not be giving you diabetes because in alpha-1 antitrypsin there is no relation to this. Wilson's disease, again, no diabetes would be seen over here. And autoimmune hepatitis, again, there is no relation. But then in hemochromatosis, if you see in the classes we have discussed that, I have done this Wilson's and hemochromatosis. So Wilson's also will involve the liver. But then, you can see very carefully that, liver is the most common organ involved. Number one, in hemochromatosis. And what kind of cirrhosis it will be giving you? Micronodular cirrhosis in hemochromatosis. Whereas Wilson's would give you macronodular cirrhosis. Hemochromatosis give you micronodular cirrhosis. So they have mentioned in this in the option, and they are already mentioned that iron deposits are seen, and they are mentioning that there is the patient is diabetic. So again, in hemochromatosis, you have pancreas involvement, and it leads to diabetes development in the patient. So again, this a direct question which came from hemochromatosis, which we have done in the classes. Moving to the 20th question, a 22-year-old multiple history of jaundice, mild hepatosplenomegaly, unconjugated bilirubin was more. The sclera was also yellowish. What they have, the students have told me in a recall, and they had asked that, out of the hereditary hyperbilirubinemia, all the 4 diseases, what will be this disease? Now this, it's a question which we have done very well in the classes, even on the 25 most important clinical MCQs which I have taken for pathology. I have discussed over there, and this is the exact diagram which we have discussed in the class. Like, in the hereditary hyperbilirubinemia, there are 4 diseases we are studying: your Kriglanjar, your Gilbert, your Dubin-Johnson, and Rotter. Now in this, they have mentioned that unconjugated bilirubin is high. So as soon as they mentioned unconjugated bilirubin is high, normally what happens is RBC gets sliced down, converted into heme and globin. Globin directly goes into the liver and gets catabolized. Heme binds with protoporphyrin, becomes unconjugated bilirubin, and then this unconjugated bilirubin is taken by the albumin to the hepatocyte, and inside the liver, the unconjugated bilirubin is going to convert into conjugated bilirubin with the help of an enzyme UGT. Once it becomes a conjugated bilirubin, then it is given to the gallbladder for storage by the help of these 2 proteins. So now, if their examiner is saying that unconjugated bilirubin is more, that means the examiner is already ruling out these 2 options. So it can't be Dubin-Johnson, it can't be Rotter. Now we have to talk about Kriglanjar and Gilbert. Now the point about the Kriglanjar is that in this enzyme UGT is completely absent. So this patient will not have mild jaundice. This patient will have severe symptoms of jaundice, number one. Then the age group which they have given it tells us that, a mild jaundice would be there in this 22-year-old. Kriglanjar, it's a very serious condition. The bilirubin rise too much. So even the age which is given in the option and mild jaundice, a little bit of hepatosplenomegaly, it all points toward the Gilbert syndrome. And the most common hereditary hyperbilirubinemia which we have is Gilbert syndrome as well. So the correct answer for this question by the question which I've got in a recall happens to be Gilbert syndrome. If there is anything extra, please let us know in the comment section below. 21st question, 10-year-old child presented with lower abdominal pain, rashes over the lower extremities, knee to the ankle, they had mentioned, and pain in joints. So, this again, by the options which they had given, obviously you can understand that, this is a case of henoch-Schönlein purpura. Henoch-Schönlein purpura, most common vasculitis in a child, number one. Secondly, IgA deposits are seen in henoch-Schönlein, and we have discussed that, the child have all these functions. This is the image which I have shown you and I have told you. Learn this image, very important image for your exam. And we have discussed this, that inside the henoch-Schönlein purpura, this all would be there. That, on the skin you will see purpura, but there will be no thrombocytopenia. Platelets are going to be absolutely normal. Then joints as arthralgia, pain would be there. In kidney involvement, IgA deposition can lead to even RPGN, and in the abdomen there would be pain. And lower extremities are generally involved in HSP. So all that they have mentioned in the question. So I, from the options and whatever clinical history I got from the students, this happens to be the right answer for this henoch-Schönlein purpura. Then glioblastoma falls in which grade of WHO tumor? Very direct question. Glioblastoma multiforme, worst prognosis tumor it is, one of the worst prognosis tumor, and we have written this in our notes very clearly that it's a grade 4 WHO tumor. It has a very poor prognosis. So the gliomas, they are astrocytomas, oligodendrogliomas, and then your glioblastomas. So, these this falls in the category grade 4, very poor prognosis, which we have written in the notes as well. Female patient with history suggestive of liver disease, hepatocytes showing ground glass appearance. There were other things also which, somebody was saying, but they were not very evident. So, anything we want to add on to this question, please let me know. So they were telling ground glass appearance was seen, and they were asking comment on the diagnosis. Obviously, we have written this, ground glass hepatocytes, the glycogen granules are missed, ground glass hepatocytes, we have discussed this. It is seen with chronic hepatitis B. What is chronic hepatitis B? When the SBS-AG antigen is present for more than equal to 6 months. So a very straight question that, the answer would be hepatitis B, the chronic hepatitis B. 24th question, most common lung cancer. Now this, what was the exact question here? Somebody was saying that smoking history was given. Somebody was saying that only the most common lung cancer has been asked. And somebody was saying that, they had asked some paraneoplastic syndrome with this. So I'm not pretty sure about what exactly was this. Please let me in the comment sections. Most common lung cancer, this table we have written, in the class, and we have mentioned this, that most common lung cancer in India, if they're asking, that's going to be your squamous cell carcinoma. But they're asking about the most common lung cancer overall in the world, that's going to be your adenocarcinoma. It happens in non-smokers and it is more common in female. So if male or female was mentioned or not, please let me know. And for the small cell carcinoma, we know that it is one of the cancers which is strongest association with smoking and with paraneoplastic syndromes. So please let me know that what exactly was the question here, so that again it might help your juniors who are gonna appear in the exam later. So these were 24 questions which came this time from the subject of pathology. There was a little, I was a little amazed by not seeing the renal questions that they have not come. Generally, renal questions, they do come. So, overall paper was okay. The kind of questions, if you see, it is not that the questions were tricky, or it is not that the questions were not solvable, or they have come from the topic which generally does not get covered in the classes. They do. Every question you can see, we have done them in the class. These are your class miss notes which you have. So they are being done. But then, yeah, some important things like, there were no questions on the lymphoma. There were no questions on renal system. So, yeah, there are some questions which they have taken from some topics which were more than expected. And there were some questions from some topics which we expect, but they were not there. But then overall, from the subject of pathology, as far as I can say, if you've studied it well, you must have corrected majority of questions from this. We know that you people have worked really very hard for this exam. Yesterday, whatever you have done, that is the, the consequence of your 4.5 months of hard work. And, you will never in your whole life, and mind our words, that you will never forget these 4-5 months of your life in which we have put everything possible at stake to get this. And when your hard work is going to be paid off on the result day, you'll be the most happiest person on this earth. So we as a team, on the behalf of